Live. All right, we are now live. So welcome to Psyfeld. This morning's discussion will focus on the sniffing accountant. So any observations?
Well, it was interesting how they all came to believe that he was using drugs without any actual evidence to prove that.
Can you give me this scene or an example?
I guess when the accountant Barry, he was talking to them in the bar and he was sniffing, and then I forget the other character's name, the one with the crazy hair. Yeah.
Kramer?
Yeah, and then the lengths that he went to prove that he was actually using drugs. And their only evidence was him sniffing, which is interesting.
Is a more widened, broad differential diagnosis.
Yeah.
So a couple teaching points here. One is more of a clinical pearl that I don't think you're going to see in your shelf exam. And number one there is that clinicians do have to maintain a high clinical index of suspicion. So especially in psychiatry, especially when you're trying to decipher human behavior and abnormal human behavior, always think that way. Always think like Kramer. Can't believe I'm saying that out loud. And that's not to be prejudiced. That's not to actually report someone. It's always to do no harm. The idea here is that you cannot possibly miss any psychiatric symptom, depression, mania, psychosis or otherwise, that is the effect of a substance. If you miss, you're going to cause your patient significant morbidity, if not mortality. So the clinician always has to maintain that high clinical index of suspicion. Of course, and to be flexible. If you go into the idea, go into a scenario, a clinical scenario, thinking that once you have evidence to the contrary, you move off of that and then you begin to broaden your differential diagnosis. So in a way, there's an embedded teaching point here, even though Kramer's behavior is obviously a little outside the norm itself. Any thoughts about that? I mean, it's not an easy thing to do either. It isn't, because people are coming to you for help. I mean, as doctors, you kind of go into school to begin with, maybe as early as, 6 years old, with this idea you want to help people. And it does feel counterproductive and counterintuitive. But if you don't adopt that stance, you're going to cause your patient harm. And it all has to do just once. It happens once, and you'll never forget, and you'll learn.
You're looking for things to kind of confirm that is what's going on.
Yeah, it's a great question about confirmation bias. Yeah, and yes, absolutely. And that's why it's so important to make sure that you check your own baggage. And that's what a psychiatry residency is all about, right? It's remaining objective, keeping true to the DSM nosology and those decision trees, and knowing that we can't label someone as being mentally ill until we've ruled out that whatever they're presenting with, whatever their chief complaint is, isn't due to the direct and physiologic effect of the substance. So yes, but as doctors, yeah, absolutely, you have to. You've got to put your patients first. And this is actually being patient-centric. It really is being patient-centered. So that begins the discussion with Barry. Now, is there information then that provides evidence to the contrary in this particular episode? That he is or isn't?
Oh, when at the very end, when Kramer was wearing the no-hair sweater and the pizza delivery guy started sniffing, and they had that really that aha moment, like, oh no, it's sweater, it wasn't actually. It's probably hindsight is 2020.
Yeah.
If you look back at it.
Yep.
Yeah, sure, you can find things to support you.
Yep. So again, just picture the scenario in which a patient like this is in a hallway like ours. And the first stop is into an office that has the psychiatrist sitting at the other end of the desk, and then walks out of that office, and then 3 steps later into another office with an allergist, and then out of that office and 3 steps later. And you can just build a scenario where when you have a treatment team meeting, when you have a case conference, there could be 6 different opinions about what's going on. Only after sharing of information can you come to a single best diagnosis. So just another way to keep it in mind, right? And we see that unfold here. Other thoughts, other observations? Actually, let's stay on this actual topic just for a second to review for the shelf. Somebody presents and you have that high index of suspicion. If you were to have written this episode differently and have Barry rule in for either cocaine use disorder, or I should say stimulant use disorder, or even stimulant intoxication, what would have been in the script? So we probably would have deleted the mohair suit scene. And what could we have spliced in otherwise?
Maybe like some change of behavior, like maybe he could have been a little bit like more aggressive or louder, or you know, like when Kramer was like at the bar with him, you could have noticed that type of change of behavior.
Yep. So we're looking at cocaine intoxication, and we're looking at both psychological and physical sequelae, the effects of the substance. On the physiologic side, what are you likely to see from acute cocaine intoxication on a shelf exam, i.e. a script that's rewritten by you?
Dilated pupils and sort of just general shakiness and jitteriness.
Yep. Right, so it's going to look like increased sympathetic tone, and really it's going to be clinically indistinguishable from a panic attack. Right, matter of fact, when people present with panic attacks and you're working them up for panic disorder, guess what you have to investigate first before you actually make the diagnosis of panic disorder? Substances in general and stimulants in particular. Right, so yeah. Let's say, and it's not, but let's say this was a two-part episode. And in the next episode, which I can assign you because this is your last day, you actually see cocaine withdrawal in the same character. What are you actually going to tell me you're now going to write into the script to demonstrate or portray cocaine withdrawal?
For somnolence, weight gain. I think vivid dreams.
Yep. Yep. So it sounds to me like a major depressive episode, right? So on your shelf exam, when you see panic attack, I want you to think stimulant intoxication. And when you see a major depressive episode, I want you to think of stimulant withdrawal. There is insomnia / sleep problems, and you're exactly right. The qualitative element of cocaine or stimulant withdrawal that does differentiate somewhat from a major depressive episode, vivid dreams. Yep. Not that people who are depressed can't have vivid dreams, but vivid dreams is a nuance to stimulant withdrawal. Any other observations on Barry?
That's when Nicole talked about the confirmation bias, the South America part, and I thought that was like really like fitting for it, because like there's like he's going to South America, he has to be buying drugs. Like it's just like they were trying to support their theory so much. That was my favorite part with the South America part. That was so funny. Even when Elaine, she was just like, it doesn't have like we can't just like rule out the entire country or continent, saying that someone's going there only to buy drugs. And they're just like, no, he has to.
That's a great point. That's a great. Let's actually take that even like another 2 or 3 levels above. What if, and again, we're going to step outside of this particular episode and this particular character. What is going through your head as a clinician if somebody were to make an appointment with you and begin to personalize or put special significance into neutral statements or neutral stimuli? Right. Right. So you're gonna probably step into that realm of psychotic disorder, and you might begin to investigate delusions and then specific types of delusions. Is there and let's say you actually build this out on a shelf exam, and let's say choice A, and you're asking for the single best answer. Choice A is delusion, but choice D is a specific type of delusion, which then would be the better answer. The delusion in which the individual puts special significance in neutral stimuli. What particular type of delusion is that? It's the idea of reference, right? Idea of reference. Also referred to as a delusional misidentification, where it's a neutral stimulus. There might be 5 people in the room, 4 of whom realize it's a neutral stimulus. I'm not going to use that terminology, but the one that's afflicted with a psychotic disorder might actually interpret it much differently. Sometimes it takes on a special or even personalized significance to them, and they could act on it. All right. I don't think that's what's going on here with Elaine and her friends, but it does make a nice segue, allow for a nice segue to teach some elements of psychosis, which, by the way, can be induced by stimulants. Any other characters you want to discuss this morning? Seinfeld, the Sniffing Accountant.
Maybe Elaine's hyperfixation on the exclamation point during her like boyfriend's message. And like interpreting it as like a slight to her and her friend as opposed to just like a neutral statement, like you were saying, like,
Nice parallel there, right?
yeah.
Yeah, yeah. You know, it's an easy segue to begin to talk about psychosis, but there's a lot of personality variables and personality traits that also, I think, contribute to the discussion as to why someone would be so fixated on such a probably irrelevant issue. And that's not only Elaine. You switch an episode and it's
Yeah.
the character number 2, and then the next episode's character number 3. What if somebody presented a clinical practice and demonstrated a pervasive pattern in this very behavior? Any questions you might want to ask them?
Probably want to sort of look at splitting, because at least for Elaine, I mean, that's not enough to diagnose her with borderline personality disorder or anything. But she sort of, this is the perfect man, you're the perfect man, you're making me dinner. Oh, you don't put that, like, how could you, like, you're the worst. So that very sort of rapid shift and sort of putting people either, none of the gray thinking, putting people either in good or bad buckets is pretty typical of borderline personality disorder.
Yeah, very characteristic. And if you're thinking this, and Elaine were to present to you with this pervasive pattern, that is clinically significant, that maybe it's impairing relationships or impairing function, interpersonal function. What are some additional questions you would ask Elaine to work up borderline personality disorder?
What relationships with others look like?
And-
Can you describe that?
And they're pretty intense and very unstable, right? I mean, over 9 seasons of situational comedy. I think that's a fair assessment. Other questions?
Any past suicide attempts or self-harm behaviors,
Mhm.
more self-harm, less like legit suicide attempts,
So,
but yeah.
When you say legit, do you mean that
I
there's
mean, actively wanting to die.
right? Often referred to as parasuicidal behavior. Yeah. Fortunately for Elaine, the character doesn't appear to be. Again, over 9 seasons. However, if she did endorse it, or if her history was in fact suggestive of or supportive of suicidal gestures, non-suicidal self-injury, what defense mechanism, if you were to engage her in psychotherapy, what defense mechanism might you address in psychotherapy? This could come up in a shelf exam.
I know you're supposed to do DBT.
You're absolutely supposed to do DBC. Yep.
But I'm not sure what defense mechanism.
It's passive aggression.
Mm.
Right? The inward turning of a nihilistic impulse. And remember, anger is a DSM criteria for this condition, so it's very often the nihilistic impulse, anger. When you can't confess or discharge it appropriately to the person that you're actually angry about, the individual who consistently turns it inward might be using passive aggression as a defense, and that could lend to suicidal gestures or even suicide attempts. Any other signs or symptoms of borderline that you'd look for in this character?
Childhood trauma.
That's interesting, because there are at least 2 episodes in which her father is discussed, and there's one that is actually in. There's something there. Now, I don't know if it's childhood sexual trauma. I don't think Larry David wrote the script that focused. But she's as an adult, she has a estranged relationship. She's very intimidated by her father. And there's even one line, and you don't know if she's kidding or not. And even if she is kidding, she might be using humor to, again, put words to the impulse that her father is an alcoholic, alcohol use disorder. Any others?
Grandma's energies.
What about it?
I don't know if he's manic all of the time, or if he has ADHD. But like in every episode, that's his baseline.
Yeah. So any particular scene in this episode you want to discuss pertaining to Kramer?
I mean, like his behavior on the bar and like his mannerisms, like he was shaky, he was like, he always moves so much, he talks really fast, jumps to conclusions. Yeah.
There's a lot of paranoia from all the characters as well.
Yeah.
Like the fact that someone's sniffing and their first thought is like, oh, cocaine, oh, they're stealing our money.
Mhm.
I don't know if that fits neatly into any type of disorder, but they all seem very, minus Elaine, prone to paranoia.
And with some irony, cocaine use disorder
Yeah.
would be at the top of the list of all things. Yeah. Yeah. Yeah, I think we see a group dynamic here as well. I don't know if we really have a group of free thinkers, autonomous thinkers. I think there is a significant element of an external locus of control, and they're very quick to adopt each other's perspective. I don't know who the ringleader is. It's often Jerry, but in this, it could change episode to episode. Yeah, with Kramer, with the rapid speech, with the flood of ideas, you'd have to think perhaps mania. The difference between mania and hypomania, these clinical terms are often interchanged and not maybe used accurately all the time. So maybe the last thing we talk about this morning is to make sure that we fully understand these relative terms. So mania versus hypomania.
I think mania generally needs to last for a week and involve a hospitalization versus hypomania can be under that sort of time frame and has a lot of the same traits, but doesn't get to the same extent where you need to hospitalize the person.
Yeah, and that's exactly right. The only edit I would make is not necessarily hospitalization. Let's just say clinically significant,
Okay,
right? Because sometimes people don't get into the hospital,
Yeah.
right?
could technically be hospitalized if someone brought them.
Yeah, I mean, there's a short list of conditions published in the DSM that are actually defined as not being clinically significant. Otherwise, for all intents and purposes, abnormal behavior gravitates or is otherwise defined as disordered behavior when you have clinical significance. Hypomania is one of those rare conditions that is actually defined by not being clinically significant. It's very similar to mild neurocognitive disorder, separating out from major neurocognitive disorder or dementia by not being clinically significant. Final thoughts, the sniffing account.
It's funny that you actually ended up wasting my money in the end.
Yeah.
Yeah, again, with some irony. And again, just Larry David puts a bow on this one. Clinical significance. With all that we're discussing, we have to go back and reconsider what is really going on here. And we may have missed the primary diagnosis, but maybe there is a mental disorder somewhere here, in as much as there's clinical significance. Individuals with this hardship of financial distress is a very common reason why people actually present to clinical settings, especially in a psychiatry clinic. We'll leave it there. For those following on Zoom, we'll log back on to our next link and see you in a couple of minutes.